Hello, and thank you for joining me today as I present on mechanisms, myths, and mu receptors, methadone and buprenorphine for pain management. My name is Peter Stussy, and I'm clinical pharmacy manager in oncology for Aurora Healthcare. I have been in this position for many years and worked with our providers and APPs for pain management, and I've also worked a lot with palliative teams to help with pain management on patients as well. I have no relevant financial relationships, and I will be discussing the use of buprenorphine sublingual tablets for pain today, which is a non-FDA approved use. After completion of this program, pharmacists and pharmacy technician learners will be able to compare and contrast dosing strategies for methadone with those of other mu opioid agonists, and describe how buprenorphine's partial agonist activity impacts its use in pain management. Here are some abbreviations that I'll be using throughout the presentation. So methadone and buprenorphine both have several different FDA approvals. One that I think a lot of people are used to is opioid addiction. So methadone has detoxification treatment of opioid addiction, and it also has maintenance treatment of opioid addiction as FDA approvals. And the higher dose buprenorphine tablets have indication for opioid dependence. I am listing only the buprenorphine only products here. There's also buprenorphine and naloxone combination products that are used for opioid dependence. But both methadone and buprenorphine have indications for pain, and that's what I'll be discussing in this presentation today. So for methadone, it's management of pain severe enough to require daily, around-the-clock, long-term opioid treatment, and for which alternative treatment options are inadequate. So the FDA labeling is really looking at chronic pain treatment. And for buprenorphine, the transdermal patches and the sublingual films that are available in the strengths listed are labeled for pain treatment. So looking first at methadone. Let's start out with a patient case, and I want to have you think about how methadone could be used in this patient as we go along with today's presentation. So we have a 58-year-old female with metastatic pancreatic cancer, chronic cancer-related pain, stage 3 chronic kidney disease with an estimated creatinine clearance of 40 milliliters per minute, and type 2 diabetes. Current pain and other pertinent medications for pain treatment are oxycodone, 40 milligram sustained release twice daily, hydromorphone, 4 milligram every 4 hours as needed, with an average of 5 doses per day, and gabapentin, 300 milligrams 3 times daily. This patient arrives today 2 weeks since their last visit at your clinic, with continued complaints of pain being 9 of 10 on a 10-point scale. This is the same issue as last visit, where medication doses were increased for this complaint. So again, let's think about how methadone might be able to be used in a patient case like this as we're moving forward. Looking first at the pharmacology of methadone, it does hit mu opioid receptors in an agonistic way. So we do have direct mu opioid agonism, which helps with pain relief with methadone. It also has kappa and delta opioid receptor binding, which also can assist with analgesic properties of methadone. And on top of this, we have serotonin and norepinephrine reuptake inhibition. As we know as pharmacists, this is a very common way that neuropathic pain is treated with our serotonin norepinephrine reuptake inhibitor medications. So methadone is often used when there are combination components in the practices that I've seen. where it is visceral and other types of chronic pain as well as neuropathic pain combined. And it's also an NMDA receptor antagonist. This particular pharmacology of methadone is thought to help with opioid hyperalgesia reversal. This is where patients, despite increasing doses of opioids, are still having increased pain, very similar to our case that was presented. The hope here is that this NMDA receptor antagonism then helps re-regulate the opioid receptors in order to make them less pain causing and more pain relieving again. Some important pharmacokinetics of methadone, and I wanted to compare it with morphine, one of those traditional mu-opioid agonist pain medications. So morphine is lipophilic and has acute CNS effects causing very quick pain relief in patients, and it tends to have a shorter half-life. While methadone is highly lipophilic, so even more lipophilic than morphine, also leading to acute CNS effects. So when you take a dose, you get some early pain relief. However, this very high lipophilic property then leads to accumulation in adipose tissues in patients. And this can lead to an extended half-life with repeat dosing of methadone, where accumulation occurs and then redistribution happens from the adipose tissue to the bloodstream. Morphine generally has low protein binding, while methadone binds to a unique protein we don't hear too much about, alpha-1 acid glycoprotein. These levels differ quite a bit in patients. So some patients have a lot of binding to this protein, and some patients have very little. And this can impact the patient's pain relief from methadone. Morphine's metabolized via hepatic glucuronidation to active metabolites, which then can accumulate because they're eliminated in a urine by renal elimination, urinary elimination. While methadone is metabolized primarily just in the liver by CYP enzymes to inactive metabolites, and it has very small renal elimination. So it's generally considered very appropriate to use in patients with renal dysfunction, while morphine can accumulate in patients with renal dysfunction. Methadone can be used for multiple different pain management uses as well. There's literature supporting use of it in surgical procedures, for acute pain, for chronic pain, for neuropathic pain, as an adjunctive pain medication, adding on to other existing pain medications patients have, and to help with opioid hyperalgesia as well. Dosing of methadone varies depending on the pain indication. For surgical procedures, it's generally a weight-based dosing given once prior to the procedure. For acute dosing, acute pain dosing, it's generally the lower dosing of 2.5 to 5 milligrams, and you can repeat it about every 4 hours as needed, although I have seen shorter frequencies as well. However, the recommendation here is to only use short term for acute pain. As mentioned earlier, repeat dosing then increases the half-life and can increase your risk of opioid adverse effects, including respiratory depression as the most concerning one. For chronic neuropathic pain, the initial dose is generally 2.5 to 10 milligrams, once to twice a day. And you generally titrate this about every 5 to 7 days. The rationale for titrating every 5 to 7 days is so that that repeat dosing can get to steady state. As mentioned, that increased half-life then leads to a general increase in levels in the body to a steady state right around plus or minus 2 days from 5 days. So this helps decrease the risk of respiratory depression and overdose with the use of methadone. For adjunctive or opioid hyperalgesia, you generally use those lower doses of 2.5 to 5 milligrams, generally once a day, and again, titrate every 5 to 7 days. Contrast these doses with those used with opioid use disorder, which generally can be much higher in 100 milligrams or more increments. Adverse effects of methadone mirror those of other mu-opioid agonists. You have GI adverse effects such as constipation and nausea and vomiting. You have CNS effects such as fatigue, confusion, and risk of addiction. You can have dermatologic effects with histamine release causing itching or rash. And a little bit more unique to methadone, there can be some cardiac effects, which I'll talk about next. In our myths sections with methadone, one myth that's out there about methadone is that it is a major QT prolonger and you should have high concern for using and increasing the risk of QT interval. In the literature, it's been shown that this truly isn't the case. Higher doses used for opioid use disorder have been correlated with QT prolongation, and especially in those patients with existing QT issues. That's where the high risk lies. However, lower doses used for pain management, generally less than 40 milligrams per day, have very little risk of significant QT prolongation that can put a patient at risk for arrhythmias. However, patients that do have prolonged QT at baseline or multiple QT prolongating medications or a family history of sudden cardiac death, the risks may outweigh the benefits of using methadone instead of a different agent for pain. Another myth that's out there is that you should titrate methadone much like we do other short-acting opiates, generally on a daily basis. This is not the case with methadone, again, due to its high lipophilicity and accumulation that occurs in patients with repeat dosing. This then puts them at risk of those overdose respiratory events. So you do not want to titrate on a daily basis, but do more of a 5 to 7 days generally. Another myth that's out there is with opioid conversions. There are lots of ways to convert current patients who are on other mu-opioid agonists to methadone. And the literature shows multiple workflows with various charts showing various conversion ratios for methadone going as high as 1,000 to 1. However, I personally prefer a more condensed, simpler conversion method, as mentioned in the McPherson reference that I have in my references. In her book, Lynn McPherson recommends the following opioid conversions, where you first look at the number of milligram morphine equivalents and then utilize a conversion ratio from there, also taking into account the patient's age. Please note that the maximum dose she recommends is 40 milligrams daily to convert any patient on any levels of MMEs to methadone. This is based off of literature showing that patients generally do not need extended higher doses of methadone for pain relief, even if they're on very, very high milligram morphine equivalents. So which patients may be good candidates and where would we might want to avoid methadone? Good candidates may be those with significant renal dysfunction. As mentioned, it's not really renally eliminated. Those with neuropathic pain, those where they've had opioid adverse events to other drugs, those with uncontrolled pain on other opioids. Again, we might be able to deal with opioid hyperalgesia, which may be occurring in these patients. If cost is an issue, methadone is available generically in multiple different formulations. Need of a long-acting opiate. So we have a cheap medication that can be used for chronic pain. It could be used in any patient that fits that criteria. However, we may want to avoid it in patients where those CYP drug interactions might make methadone levels unknown. So you may want to avoid it if there are listed drug interactions that are out there. Those with existing cardiac arrhythmias, the risk still may outweigh the benefit, even though there really isn't strong literature to support increased risk of arrhythmias. If there are societal barriers, if it's a patient who may struggle with taking meds on a regular basis or may take their meds not as prescribed, a history of noncompliance is listed there as well. Because of that risk of accumulation and respiratory depression from accumulation. If there isn't a prescriber to prescribe methadone, this is a barrier I've run into with the teams that I work with. Sometimes where the patient's being treated for pain, that particular prescriber who is their pain treatment provider may be uncomfortable and not familiar with the use of methadone for pain and thus will not prescribe it. Also, if patients have interventional procedures planned, which may change their pain level very acutely, we definitely do not want methadone on hand and have too high of a dose of methadone in place before those interventional procedures. So in summary, methadone is effective for acute, chronic, and neuropathic pain, to name a couple of possible options. In general, you want to titrate slowly every 5 to 7 days due to lengthening half-life that's occur with repeat dosing to avoid adverse effects. It's great for patients who need long-acting agent but need an oral solution as well. I want to note that as it can be used through feeding tubes and other types of GI tubes as a long-acting agent, which really isn't available in our other sustained-release opioid formulations. QT prolongation is really not as large a concern as some might think, and there are many conversion options for moving from other mu opioid agonists to methadone, but you can generally keep it simple with the McPherson method. So revisiting our patient case. Remember, here are our pain medications she's on right now. She's been having escalated doses, but continues to have uncontrolled pain. So methadone may be a good option, but what dosing strategy should be used if we're converting to methadone in this particular patient? A, 2.5 milligrams daily, B, 100 milligrams daily, C, 5 milligrams 3 times daily, or D, methadone should not be used in this patient. All right, in this case, the answer is C, 5 milligrams 3 times daily. So we have a patient who's not responding to escalating opioid doses, so methadone could help with what might be opioid hyperalgesia in this particular patient. Patient does have neuropathic pain as they are on gabapentin, so we may be able to look at that as well. And there are no drug-drug interactions or cardiac concerns with this particular patient that I mentioned. So no indications to not use methadone. So looking at why we chose 5 milligrams 3 times a day for methadone. Our milligram morphine equivalents are they're taking oxycodone 80 milligrams daily, which is approximately 100 morphine milligram equivalents, and hydromorphone 20 milligrams daily on average, which is another 100 milligram morphine equivalents, for a total of 200 milligram morphine equivalents on a 24-hour basis. So if we used our 1 to 10 ratio, that is right on the border. 200 is right on the border of our conversion table. So we could use 10 to 1, and that would be 20 milligrams of methadone. Or we could use the 20 to 1, and that would be 10 milligrams of methadone. Or we could split the difference because there are 5 milligram tablets that are available. So doing 15 milligrams a day makes a lot of sense. 5 milligrams 3 times daily, and then add in an as-needed medication on a very regular basis whenever you're converting an opiate. Here we have as-needed hydromorphone every 2 hours. So when you're pulling off those other opioids, you have some options. You can just stop those other opioids the patient's on. However, we have a patient with uncontrolled pain, so we may want to take the option of continuing it for at least a little while. In this case, we might want to use oxycodone 20 milligrams twice daily for 3 days and then stop it, or even longer, depending on the patient's pain. You can consider decreasing and stopping gabapentin as well if the neuropathic pain also improves while they're on methadone. All right, we'll finish up today's presentation with buprenorphine. So again, looking at a patient case where buprenorphine may be an option. We have a 43-year-old status post motor vehicle accident with severe orthopedic leg injuries. They are on a patient-controlled analgesia after surgery with hydromorphone during the postoperative period. Need for several months of chronic pain control is anticipated. A patient has a history of opioid use disorder, but has been in remission for the past 10 years. The last 48-hour PCA usage is a demand dose of 0.2 milligrams every 15 minutes, and they've used 10 doses in the past 24 hours. And their basal has been a 0.2 milligram per hour dose. So buprenorphine pharmacology, it also hits several different receptors. You have mu-opioid receptor partial agonist activity. So it has very high affinity and a slow dissociation. This activity then leads to analgesia, but also has some beneficial effects in our pain management patients. It tends to then lead to a ceiling on respiratory depression and euphoria with use of buprenorphine. It also helps to limit GI mobility issues such as constipation, physical dependence, abuse, and withdrawal potential. Along with the partial agonist mu-opioid receptor activity, we have delta and kappa opioid antagonism. Little different here. So it limits the addiction and tolerance issues that we may see with other opioids. And it also, again, limits that GI mobility and respiratory depression issues. Also, it has opioid receptor-like 1 or ORL1 agonist activity. This leads as well to diminished opioid rewarding as well as limited tolerance. So lots of interesting pharmacologic effects, which all leads to good pain control, but a lot less of the concerning things we have with other opioid pain relievers. For pharmacokinetics and dosing of buprenorphine, we have a pretty long half-life of both the buccal film and the transdermal patch with buprenorphine. So it's generally a chronic medication when used in the outpatient setting for pain. For the buccal film, it's generally dosed daily or twice daily, and it takes about 3 days to reach steady state with the transdermal patch. It's metabolized hepatically via CYP3A4, so you do have some risk of drug interactions. You can see the patches are available as 5, 10, 15, and 20 microgram per hour. For naive dosing, you start at a 5 microgram per hour. And with patients with milligram morphine equivalents of 30 to 80, the FDA labeled dosing then recommends a 10 microgram per hour start with titration to the higher patches as necessary. The buccal film comes in the doses listed here, and for naive dosing, you start at the lowest dose, 75 micrograms, once to twice a day. And with different milligram morphine equivalents listed there, 30 to 89 or 90 to 160, you start with different doses and again, titrate up based off of pain needs. For adverse effects, again, we see similar adverse effects to other opioids. However, it's seen much less than other opiates. You can still have constipation, nausea, and vomiting, but it's much lower incidence. One of the unique aspects of the sublingual and buccal formulations is that they can have some dental adverse effects, possibly due to the acidic medication formulation, such as tooth decay, cavities, and infections. QT prolongation is also listed as a possible adverse effect. Dizziness and drowsiness, risk of withdrawal if you're starting a patient who is on very high doses and of opiates, and respiratory depression is still a risk, although much less than other opiates. So some of the myths with buprenorphine, going back to that QT prolongation. I know this is something that I was taught along the way, that this is one that should be avoided for QT prolongation as well. But when you look at the FDA labeling, it states right in it that there's no major QTC prolongation. And European dosing actually goes to patches up to 210 micrograms per hour. So we can use much higher doses safely, most likely, than what we have available here in the United States. So those buccal films are equivalent to going up to those higher doses of patches that they use in Europe. Another myth is that the buprenorphine at the patch and sublingual films precipitates withdrawal always if started in an opioid experienced user. The dosing recommendations are in there with the labeling, and there are lots of transition methods that are available in the literature, which unfortunately, due to this being a shorter pearl, I don't have time to cover today. But you really can utilize these lower microgram doses and not precipitate withdrawal in patients if it's done correctly. Another myth is that you cannot use buprenorphine if they need, you can't use as needed opioid agonists as needed for acute pain when patients are on buprenorphine. Those effects will be blocked. That's not true either. Our patches and sublingual films are dosed in micrograms, while our opioid use disorder products are generally dosed in milligrams, much higher doses to help block opioid receptors for opioid use disorder. And there are plenty of mu opioid receptors available at those lower doses to help with pain relief with as needed immediate release opioid agents. And another myth is that those higher doses don't offer any pain control. They're only opioid use disorder, and that's not true either. Those higher milligram doses can be used off-label to help with pain control in those with higher opioid needs as well. So what patients would we want to maybe use buprenorphine in? Those with an opioid use disorder history or other drug abuse history have been recommended because, again, it has far less of those addiction impacts and effects. It's also been shown to possibly help with those with anxiety disorders. Patients on concomitant sedating medications, again, less opioid adverse effects in the CNS then leads to less overall sedation in those patients. Older adults who may have more opioid adverse effects. So seeing a pattern here, those patient groups who may have more opioid adverse effects to pure mu agonists, buprenorphine might be a great option. But truly any patient with a chronic pain need requiring an opiate, buprenorphine might be a great option to help with their pain. But we also need patients whose insurance covers buprenorphine for that pain indication, and that can be a barrier. So in summary, we have buprenorphine can be used much like other opioid pain relievers. It has sublingual and patch formulations for chronic pain. You can use shorter acting opioids for the acute pain as needed while patients are on the longer acting buprenorphine products. Patches and lower dose sublingual films have very low risk of precipitating withdrawal if used appropriately and dosed appropriately. And insurance prior authorization or higher copays may limit the ability to use buprenorphine in certain patients. So let's revisit our patient case. So we have our demand doses here of 0.2 milligram every 15 minutes. They've used 10 in the last 24 hours, and a basal of 0.1 milligram per hour. How could we convert this patient to buprenorphine? Well, here, which dose would be best to start in this patient? A 5 microgram per hour patch, a 10 microgram per hour patch, a 300 microgram sublingual film daily, or buprenorphine should not be used in this patient as they will go into withdrawal. So answer here is B, buprenorphine patch 10 micrograms per hour. And our rationale for that is here. We have a 2.4 milligram basal plus a 2 milligram demand in 24 hours for this patient. This is approximately 55, right in our range to use our buprenorphine 10 microgram per hour patch for this patient. And then make sure that you have some agent. In this case, I gave an example of morphine 15 milligram IR every 2 hours as needed for acute pain breakthroughs as well. So that is the pearls I have for methadone and buprenorphine today. Any questions, please feel free to email me at the email address listed here. Here is our CE code for today's presentations. And again, my title is Mechanisms, Myths, and Mu Receptors, Methadone and Buprenorphine for Pain Management. Thank you very much for listening.